Hello, everyone. I'm going to be talking to you about Wellens syndrome. It's the exception to the rule. And let me say this up front. If you don't know what Wellens syndrome is, then someone could walk right past you with a ticking time bomb and you would be sending them home. Because this ECG, it doesn't just scream. Yeah, so this ECG doesn't just scream. It whispers. Sometimes you don't have any ST elevation. That's quite classical anyways. No chest pain when you see them. Anthroponians might not even care. But the left anterior descending artery, which we call the LAD, is hanging by a thread. And if you miss this ECG, the next time they feel pain might be the last. Wellens shows up in 10 to 15% of all unstable angina cases. That's not rare. And here's what makes it terrifying. It only shows up when the patient is pain-free, right? And that's when the real danger reveals itself. What's causing it is critical narrowing of more than 90% of the proximal LAD. That's the artery that supplies the big front wall of the heart. You block that and you can get a massive anterior MI, the kind that quickly or leaves you with a half-dead ventricle. What is Wellens syndrome? We have an ECG here. So what is Wellens syndrome? Wellens syndrome is a pre-infarction warning sign. The heart is gasping. It's not yet dead, but moments away. There is no ST elevation. There's normal-ish troponins, no Q waves, but there's this subtle, suspicious T wave pattern, and that's your last sign. As we can see here, for instance, again, I'm annotating. What do we see here? In the anterior leads, what do we see, right? Not accurate here, but as you can see here, there is T wave inversion. And so this could be your last warning. And if you think stress testing will help, please think again. Stress testing is contraindicated. And you'll just be provoking a full-blown infarct with stress testing because these patients will go straight into angio, not the treadmill. There are two ECG patterns. There are two types. There's type A, where you have your biphasic T waves in V2 to V3. This is less common, but often more dangerous. The T wave goes up and then dips down. Think of it like the heart is trying to sit up, but then it's collapsing. Then in type B, what you have is, and this is in 75% of cases, is deep symmetrical inversions, mostly in V2 to V4, sometimes going all the way to V6, but this is what they call LAD wave syndrome. These aren't from electrolyte issues, they are subtle anxiety in fact. So they are the footprints of a starving heart. Sorry. So the script, the patient will look calm. They'll say, "Yeah, I had chest pain, but it's gone now." Troponin may be a little raised, maybe not. Vital signs might even be stable. But the ECG tells the truth. If you know how to listen, these T waves show up after the pain. It's like the heart is trying to warn you while catching its breath. And here's the twist. During pain, the ECG might look normal again. That's called pseudonormalization, which means if you only check one ECG, you might miss it entirely. Now let's talk about a case. You have a 61-year-old man is walking his dog, gets chest pain. But by the time he gets to you, the emergency department is telling you, "Oh, I'm sorry, doctor. I'm sorry if I wasted your time. I don't want to be such a waste. I feel like a fraud." And he's saying, "Right now, I don't have the chest pain anymore." And it's chilling in the chair. And you run an ECG and boom, you see this biphasic type of T waves. There's no chest pain, no panic, no panic, but that ECG was screaming Wellens. Angio confirmed it, 90% LAD stenosis, and he got a stent that same day. This is a real case, right? I kind of tweaked the age a bit, but this is one of the real cases that we see with Wellens syndrome. And here you can see pictures here. You can see the coronary angiography revealing a tight proximal left anterior descending artery stenosis. And here you can see after a stent placement what it looks like. You can see that the area of obstruction has now been resolved. And this is an electrocardiogram 2 weeks after the left anterior descending artery. Normal sinus rhythm resolved T wave inversions from figure 1. So this was Same person we had this first figure from, right? And now you can see the T-wave inversion has all resolved because somebody somewhere recognized the signs and activated the cath lab. Now, in case two, you have a 68-year-old woman with recurrent chest pain. Normal vitals, TROPS, the ECG during the pain-free period showed T-wave inversions. Angiography was done and revealed LAD stenosis and a stent was placed. Another life saved by somebody recognizing Wellens. And this is what we say about, ECGs. This is what we say about knowing your bread and butter with ECGs. We don't think it's important to know every bit of ECGs, but you should be able to recognize abnormal signs and recognize the killer signs. And all of this is fully covered in our course. It's on our website, it's on our Instagram page at ECG underscore decoded. Um, and you can get that course. But really, these are cases where lives were saved because somebody somewhere had listened to a lecture like this, had practiced, had looked at more examples, had maybe done a course or not, but were aware that T-wave inversions by phasic T waves, even in a chest pain-free person, could be the first sign of a LAD. Now, the ECG types, we talked about this before, right? Type 1A is biphasic T waves. It is more dangerous. It's mostly in V2, V3. Don't blink and miss it. In type 2, you have deep symmetrical T wave inversions. This is what medics often write off as non-specific changes. Please don't do that. And these are not vague changes. They are specific, predictable, and deadly. Now, the diagnostic criteria. Yes, how to diagnose it without overthinking it. Let's just make it simple. Just go through the stages. Do they have chest pain? If they've had a history of chest pain, then yes. If the T waves look weird, they look either biphasic or deeply inverted in V2, V3, yes. Are there ST elevations or enzymes rise? If no or minimal, we're still talking Wellens, yes. Was the ECG taken when they were not in pain? Yes. Then you have your criteria settled for, right? And that's Wellens. You don't need more tests to suspect it. What you need is action. Why early diagnosis matters is that, this is the slide I want tattooed in every A&E department. I want you to think Wellens equals critical left anterior descending lesion. You do a stress test, you might give them the infarct you were trying to rule out, but that's not theoretical. It happens. Serial ECGs will help. Look at T waves over time, but don't sit on it. Wellens is a gift. It's the rare ECG that gives you a warning, right? You listen to it, you act on it, and you save someone's life. Here's what I want you to walk away with, right? Wellens means pre-infarction, and it means you need to have fat. It shows up when the pain is gone, it screams through subtle T waves, and it demands unjet angiography, not reassurance. Do not stress test. Do you want to learn all the 7 other ECG patterns that kill quietly like this, that people do not really know, but it's a big deal in emergencies or not even emergencies, in cases you just don't want to be that clinician that misses something important, do you? If you do want more of critical information like this, subscribe or DM me the word decode. This is what we do. Comment decode. This is what we do. We watch the killers before they kill. Thank you and have a great day.